Hello, everybody, and welcome to another presentation provided by the Southwest Council. My name is Lisa Zimmer, and I am joined by my guest today, Kelly Edelman. Today, we're going to be discussing healthcare decision-making and advanced directives and why it's so important to have those set in place. So, Kelly, can you begin by telling us a little bit about yourself and what it is that you do?
Sure. So thanks for the introduction, Lisa. My name is Kelly Edelman. I am a nurse, an RN. I've been an RN for about 11 years. I have my master's in nursing education. I'm also a certified rehab RN as well as a certified brain injury specialist. And I'm currently, my background is working in rehab, specific to like physical rehab, like brain injury, stroke, things like that. Medical surgical background, and currently I'm teaching a nursing program down in Cape May, so I'm a full-time educator at the moment.
And you have a lot on your plate, and you do everything very well. And I've met a lot of your students, as you know, and they all adore you, and I can see why. So first, I want to start by saying that the topics that we're going to discuss today aren't necessarily the most fun or maybe the most enjoyable for some people. It can be a little bit stressful, maybe a little bit uncomfortable, but at the same time, it's really important. And I also think the more that we discuss things like this that are difficult, the easier that those conversations become. So I just kind of wanted to just acknowledge that that's a situation before we get rolling here.
Yeah, and I think it's a topic that, as we had said before, it's it's applicable to everybody. It's not just, oh, this doesn't apply to me because I'm not, not a senior citizen yet, or,
Yeah, and as we'll get into, we'll discuss a little bit why it is for everyone, right? And not just older adults or not somebody with already a pre-existing illness. One of the things that I've noticed lately is, and I don't know why it's just lately, maybe it's because I'm just paying more attention to it, or maybe because it's just being done more often. But when I am going to doctor's appointments or checking in place, even when I go to like the radiology place, everything, I am asked whether I have an advanced directive in place. And so it turns out, right, that this is an actual law. So when you go to a medical facility, right, they are required by law to ask you if you have one, and then also provide you with that information if you request it. Is that correct?
Yes, if you said no, then they would, the rebuttal would be, would you like more information on how to create one? And then they would either fix you up with, they would give you resources to do that.
Okay. So advanced directive has a lot of different names that people may even be more familiar with. And there's a lot of terms that we're going to be talking about today that are interchangeable with other things and can get a little bit confusing. So I thought we could go through and kind of break down what these terms mean, what they're also known for, and try and get that all settled before we start. So why don't we just start with, when we say advanced directive, like what does that mean and what else have people heard of?
Okay, so an advanced directive, I always look at that like an umbrella term. So when we're talking about, do you have an advanced directive? I think, like you said, a lot of people are like, I don't really know what that is. Maybe I have part of one. I didn't go to a lawyer. I don't really know. But really all that is indicating is that there's some amount of oral or written instruction somewhere about what you want your medical care to look like if for some reason you can't make your own medical decisions. So if you are unconscious in a motor vehicle accident on the side of the road, or you're too ill to communicate, something happens, there's no way for you to communicate your wishes. So it's an all-encompassing term for all of the other terms that we're kind of going to discuss this morning. Okay, so saying the advanced directive is your umbrella term, then you have the other terms that people hear all the time, which is a living will, which I think is probably the most commonly utilized term, and also power of attorney, a healthcare proxy, things like that. So all of those things are included in an advanced directive. They're part of it. So a living will is typically what's going to be written down. And that's also known as like an instructive directive, because it's almost like you're creating a set of instructions on, if I am unable to communicate my wishes, this is what I want to happen in writing. So that's your living will. It's sort of your written document component. Within that living will, you may designate what you might call power of attorney. Now, there are multiple types of power of attorneys. There's a healthcare power of attorney, right? So your living will can be as specific or complex or as simple as you want it to be. So you can designate different people for different things. If you're unable to make your own decisions, it can be one person who does all of it. But when we talk about a power of attorney, you can have a healthcare power of attorney. There's one that does that, one that handles the healthcare, one that handles the financials, one that handles the estate, one that, there's like different ones. So in our terms today, talking about power of attorney would be referring to that healthcare power of attorney.
Right.
And
that healthcare providers can also do those other roles if so designated, but doesn't have to, right?
Right. It depends on if that's what's designated exactly in that living will. And a person may, a mother may say, well, my one daughter's a nurse, I want her to be my healthcare power of attorney, but my son is an accountant, so I want him to be my financial person, and so that they can designate that within that living will.
Mm-hmm. All right. So that makes perfect sense. When we talk about the living will being like kind of as simple or as specific as you want it to be, later on in our conversation, we're going to be talking about like those specifics. And one of the reasons why I wanted to bring a healthcare provider on is because you have some better, definitions and some better examples of what those specific situations and conditions can be. One of the things that we had just talked about before jumping on was HIPAA. So I do want to touch on that. Everyone has been asked about HIPAA. Everyone knows what HIPAA is at this point, right? Because when the HIPAA law went in effect, and now every single year, right? It's annual. I believe you have to re-sign. Say, can you sign this? And do you want a copy? And you say no. But what I found is that a lot of people really don't understand what they're signing. And so just talk about like why that's important and what it actually is.
Yeah, so HIPAA is a Healthcare Insurance Portability and Accountability Act, and that was in 1996. It was formally created. But all that means, when we call it HIPAA, is just it's patient confidentiality. And so legally, as a healthcare worker, I am not allowed to talk. If I was your nurse, I am not allowed to talk to anybody else about you and your diagnosis or your situation. The only other people I'm allowed to talk to, if I was your nurse, is other people involved in your medical care. When you are admitted to a facility, or you go in for an elective procedure or anything, there's usually going to be a list of who do you want, who is it okay that I contact? Mm-hmm. Or you do that at your physician's office, your primary doctor or specialist, and when part of your account is going to be who am I allowed to speak to, and that then becomes okay. Sometimes we create things like a password that the person has to give us, so that I know that they're the person they're saying they are, and things like that. But yeah, that has to be in writing by the patient. Otherwise, in order to protect your own personal information, that's what HIPAA is in place for. It's to ensure that there's confidentiality, that no one else has access to what's going on with your medical care that you do not want to have access.
Yeah, and I also want to mention that this really is much more important than I think people think about, or maybe they bypass it. But I know I had mentioned this to you a few weeks ago, is my mother got very sick and had to be taken to the hospital. And she was home by herself, so nobody knew anything had happened to her. And I got a call from the hospital. And they said, are you so-and-so? Are you Lisa Zimmer? Yes, I am. We think we may have somebody here that is important to you, and and are written down, and you're written down as their emergency contact. Can you please verify like all of your information? So I had to give all of my information, and then they're like, okay, we think that we have your mother here. Can you give me all of her information? Okay, date of birth, her address, all of her information. And then like, okay, so this is what happened and this is what you need to do. And I often think to myself, if she hadn't written me down, right, if she hadn't taken the time to
Right.
do that, no, literally no one would have known, and had been able to be there for her. So I do suggest that
And your mom had been, what had brought her to the hospital?
heart attack.
Was it was a heart attack.
Yeah, she
So
had,
she was unconscious.
she was, by the time that, yeah, she was conscious enough to call 911, and then by the time they got there, she was already out. And then
And
she didn't wake up until she was in surgery and they cathed her. And as soon as they busted the clot, she woke right up and was like,
wow,
"Hey." And the doctor's like, "How you feeling?" And she was like, "I'm feeling fine.
wow, yeah.
No
That's
problem anymore."
lucky.
But and also that was during COVID, so I wasn't able, to go and see her when that happened. And she is very, and I don't mind speaking about it. She is very open and comfortable with me talking about it, because she says, especially being a woman, sometimes women have different signs and symptoms of heart
Absolutely.
disease. So she likes me to speak about that, just
Mhm.
so other people get the education. But again,
Yeah.
yeah,
And
she
you
was
know what, that's a
unconscious
perfect
the whole
example.
time. Yeah.
Right, because that could be anybody. I mean, I say a car accident, or it could be a heart attack, or it could be you fall, or something happens, you hit your. If you're taken to an ER and you are not able to, they have no way of getting any emergency contacts, and then you're unconscious. So what then do we do? Well, we work in the best interest to save the life of the patient. That's all that we can do, until we can. And then meanwhile, we're scrambling to try to find an emergency contact somewhere. And
Yep.
so, yeah, if the more, you are, I think, and you know what I think it is, another piece of this is that when you are a new patient somewhere, if you're a new patient in a doctor's office, if you're a new patient in a hospital, if you're new, wherever you are, there is a ton of paperwork you have to file up front, right? And it's a pain in the butt. You're like, okay, I wrote my date of birth 15 times. I wrote my name 15. I already wrote my insurance, right? And so I think we don't think about how important that paperwork is that you do in the beginning, because taking the time in the beginning, to make sure you're saying, yes, I want my information shared. These are the people that I can share that information with. If that's written and you take the time to make sure all of those things are filled out properly up front, then God forbid you run into a scenario where you are ever unconscious or unable to make your own decisions. There's documentation somewhere that they can pull, that they can find, that they can go from. So it's important that people take it seriously, because it is a pain. It's always a lot of paperwork when you're starting out somewhere that nobody tends to want to do, or they just kind of just write it really fast. But it can be a lifesaver, literally.
Yeah, absolutely. And that next day, when she was in the hospital, her nurse helped so that I became her official healthcare proxy while we were there, like that I was listed, so that if anything else were to happen, then that was just not just an emergency contact, but that I would be in place for her healthcare proxy if something else were to happen. So like we were saying, things just happen. We can't plan it to happen. We get in a car accident. We have a medical emergency of a condition we didn't know we had. All of these, unfortunate and terrible things can happen. So when we ask the question, like, who needs an advance directive? Who needs this living will? Like you said in the beginning, it's not just older adults. It has to be everyone, right? Because anyone can have these kind of things occur, right?
Yeah. Yeah. I mean, I think people tend to think that that's something, again, for the older adult, or, okay, I'm getting close to retirement, or I just been diagnosed with diabetes or heart condition, or, okay, now maybe I need to start thinking about, people tend to wait for that stuff. It's almost like a 401k or retirement plan. You're like, oh, I'll think about that later. That's, it's not
It's
applicable right
always
now.
the wrong thing to do, right? And you realize
Right.
it when you
Right.
hit 50
Always.
and you're like, oh my
Um,
goodness.
darn it. Yeah. So it's very similar situation where, and I think the other thing too, I think another thing, like even for me as a young mom, right? I think, who I would have, or say before I was married and then I get married, or who I might want to be involved in my care if I was unable to make my own decisions, that's going to change throughout the years. It could change. And so I think another thing people tend to think about is, well, I'll just wait until I'm older because then, it'll be correct, or, so I think the other thing too is it's important to make one at any age, but it's just as critical, regardless of what age you make it, to make sure that it's current. because who you want to be involved in your care is very likely to change over time. And yeah, I mean, I've got a 3-year-old son at home. What if he, in 20 years, he's a nurse? I might want him versus my husband to be my power of attorney, healthcare power of attorney, if he's more knowledgeable of the healthcare field, right? Or might have been my mom before I was married, and then I get married, maybe, and now I want it to be my husband, and that's stuff that we can always
she
change.
gets older, and that at that point would be too much of a stressor, and so you want to bring it down to somebody else.
So it really is critical to have in place at any point, because realistically, life is fragile. We don't ever know when something's going to happen. And one of the other big pieces to this is, if a patient comes into the hospital, say they were unconscious, and they don't have any sort of existing advanced directive, healthcare workers go, okay, now what are we going to do? Now we've got to talk to the family. We've got to try to make the best decision with what we call the next of kin, who would be, by definition, it's typically the spouse, and then the child, and then there's like a hierarchy of who we would consider being the next of kin. And then regardless, that's the person who has to be designated to make your medical decisions. You may not want that person to be designated, but if we don't know, if we don't have that in writing, then we're doing the next best thing. And so that also creates a lot of stress with the healthcare team, because we ideally want to do what you would want us to do, right? But at the same time, it's also going to create a significant amount of stress with your family, because they may not know exactly, what you want to do. For instance, there was a friend of ours whose husband had cancer in his ear canal, and so he had to go in for surgery to try to remove it. And he's on the operating table, and they realize the cancer is much further in than they anticipated. So they call his fiance, wasn't married to her yet, because she was written down as his next of kin at the time, or the person that is like a healthcare proxy that was emergency contact. And they say, look, we either call it now, we'll stop surgery, and we will allow him to go get chemo and radiation. We'll try to treat it externally, but then we're leaving some cancer there. They said, or we can keep going and try to get it all out, but he'll be pretty severely disfigured. What do you want us to do? And meanwhile, he's on the operating table and he's unconscious, right? So that's a very heavy decision for someone to have to make, not knowing, okay, what would they want me to do, right? That's a lot of anxiety. So when you have situations, and there's so many millions of scenarios that can happen that you can't anticipate all of them, it really helps if there's something in place that designates pretty specifically what you would want. And it makes the family feel a little bit better too, because it's less on them that, did I make the right decision for my loved one?
Yeah, I was just thinking about that. It's something that I didn't consider, but say you have, your advanced directive in place. I'm sure if you knew you were going in, you and I had also talked a few weeks ago about the situations of elective procedures that are routine and that people go through all the time, and every once in a while something goes wrong, and you may think that it's going to be kind of an in and out, open and close thing, and it turns out to be a much bigger deal. And so why it's important to have that advanced directive in place. But I'm sure that if you were going in for a surgery like that, you could just add an addendum, at the end of that, or add a page specific to, okay, I know that I'm going to be having a procedure done. Let's write some things up specifically about that procedure if that happens. And
sure,
it seems maybe, like a little specific, but when you hear that kind of story,
right,
it doesn't seem so trivial anymore. It seems like, yeah, that would be a big deal. So I would like,
and I think
to make the decision,
Yeah, and I think people think that, you don't have to have a lawyer for this. Realistically, I mean, you can write on a piece of paper, this is what I want to happen, and you can get some key witnesses to sign and date. It doesn't even really have to be notarized, at least in the state of New Jersey. So it's something that you can write down. The other thing that I thought was actually really important when you look into this a little bit more, and I think it says this on the New Jersey website, is also maybe adding in, when you're writing up that living will, or your personal values and beliefs.
Mhm.
Like, if you're a religious person, what do you believe? What do you hold valuable? At what point is life? If there's anything specific to what you hold valuable and what you believe,
Yeah, because well,
even if it's
there's medical stuff, right? That it's like, okay, we would consider somebody, and we're going to go into these terms as well, right? But we would consider somebody brain dead, or we would consider somebody unable to make
right.
decisions, and therefore all of these things would happen. But maybe your particular belief is that, well, not until this happens or when this
Right,
happens do I
exactly.
feel like I would not want to go any further, right? So they may be
Right.
conflicting in nature, which is,
Yeah.
why I think what you're saying is so
And I
important.
think that makes, if that's not written down, the families are going to tend to feel more guilty about, am I making the right decision? Because I don't know, because it's not. And you know what, the other piece of it is too, is just discussion. I mean, I'm a very big proponent of, being transparent with this kind of thing. You talk to your loved ones, your closest family, and say, you bounce ideas. You think, this is if this happened, this is what I would want. Or, because then, even if it wasn't written, if you're talking to whoever would be that healthcare power of attorney, they are going to have a better idea of what you would want.
Mhm.
And so it's something that people always get freaked out talking about, because it's almost like it's taboo. Like, I'm gonna die if I talk about my
Yeah.
living will. But it is important to have those kinds of things, that you do discuss it, because things, can happen. um so yeah, I mean, it's not a bad thing to have an addendum, or have a pre-conversation, like, look, if this came up, I trust that you're going to make the best decision. This is really what I would want. Or, can you sign? And you sign, and you sign. Usually they like to have like two witnesses, I believe it is. And then that just helps everybody feel a little more comfortable with the decisions that are made.
Yeah. Now, at the end of this presentation, I'm going to have some things up on the screen, a couple different free resources where people can print out templates where you can just write in your information. You can just circle, just something as easy as, yeah, that's what I would want in this situation. And you can circle it. And it does break it down just to make it a little bit easier. I do want to talk now about what those decisions can be, or what like some common situations are. Like I say, kind of like getting into the nitty gritty of, okay, I'm feeling overwhelmed. There's how could I possibly know what circumstance is going to happen, and to be able to know what I want, and how can I write all that down? Well, it's like, thankfully a lot of people have already done that for you. So you just have to
Mhm.
find the resource and then be able to just read and say, oh yeah, that's what it is. So
Yeah.
when we talk about all of those options about life sustaining treatment and withholding treatment, there's again a million terms. So I'm gonna rattle them all off, the things that I want to touch on, because obviously they're all related. But things that you're commonly going to see when you look into these resources and starting to make your advance directive, a do not resuscitate order, DNR order, which is fairly common for people to be hearing. Artificial nutrition and hydration, intubation. Unfortunately, we've been hearing a whole lot about that with the recent pandemic. Life sustaining treatment, mechanical ventilation slash ventilator slash respirator, right, which are all kind of the same thing. What terminal means, palliative care, hospice, withholding or withdrawing treatment, and then brain death. So, a lot of these we have heard of and we think we kind of know, but from your kind of like medical perspective, when you like hear them, like just kind of an easy, normal person's way of explaining that.
Yeah, and they are all terms that we do see all the time in healthcare. It's, one of the things that we take for granted, I think, is, okay, like, somebody decides, okay, I want to be a DNR. Great. Do not resuscitate. Okay, so you make that decision, but then there's a rabbit hole here. So you want to be resuscitated or not. So that would be what we would call a full code. A full code would be somebody who wants all the works. If I'm coding, if something happens to me, do everything you can to bring you back regardless. That would be a full code. But if somebody decides that they do not want to be resuscitated, there's more to that. So you can say, do you
Under
not
what
want to be
circumstances, right?
right? Well, exactly. Or if you're being resuscitated, right, exactly. With circumstances, you can be resuscitated, but then also be intubated. So then you'll see somebody say, they're what we call a DNR, DNI. Do not resuscitate, do not intubate. Then there is a DNR, DNI, DNH. Do not hospitalize. So you could have somebody who maybe have some conditions, who goes to the doctor, takes medications, but says, if something happens to me, it happens to me. That's God's will. Let me go. And so they may have what's called a DNH, even a do not hospitalize. So we see that a lot in like long-term care centers, where if somebody starts to get sicker and sicker, okay, you can treat me, but I don't want to go in the acute care hospital. That's not where I want to die. So all of those pieces, and you're right, people don't think, it's hard to wrap your brain around the different facets of what could happen. So following, again, you don't need to use these forms that are available, but they're helpful because it is written in a way that it's going to make you think about questions that you have trouble anticipating. It's going to help you kind of answer those questions.
What is the difference between like resuscitation and intubation? Can you just say the difference between the two of them?
Yeah, so resuscitation would be if you're getting, CPR, compressions and ventilation and things, and you're brought back. That's resuscitation. You're brought back from being a flatliner. Your heart had stopped. But what may happen is maybe we get your heart going, but you're still not breathing independently. And so then we have to what we call intubate, which is really just putting a tube down your throat, and that's or your airway really, and it's breathing for you. So you can be kept alive on once you're intubated, you're put on the ventilator, and the ventilator is what more people are hearing now with COVID. People get put on the ventilator, and it's really hard to get off the ventilator because what happens, your lungs actually get what we call lazy. They get lazy. So if you're put on a ventilator that is causing you to breathe on its own, you're not breathing on your own. So it gets then very difficult to take somebody off of a ventilator because we've got to get them lungs to start actually working on their own. So then you're being kept alive with a machine, right? So and then the other piece too is you talk about artificial nutrition and hydration. So you have IV therapy. You have let me put in a nasogastric tube to give you to feed you that way, or something we call TPN, parenteral nutrition, where we're giving you nutrition through an IV or through a tube in your stomach. So all of those things mean if you didn't have those things, you would die, right? So they're all potentially things that are keeping you alive. And some people don't want to live that way. And so once you're resuscitated, okay, now what? What if you're resuscitated and you are on a ventilator, or you do need the artificial nutrition because you're still unconscious, or comatose or something like that? So it gets,
and then
there's a lot of pieces to it.
How long, right? So like, I know a lot of people in their advanced directives are like, okay with all of those things, if they see an end, right? If the doctors there's going to be an end to that. Okay, well, we're going to do all of these things, but like, we think that we're going to be able to, get this person to the other side, so what you may want is going to be different. If you know that, well, we don't really know if this is going to do it, if we're going to be able to bring it, then your decisions might be different.
Absolutely. And I think your term terminal is what comes to mind here, right? When we start talking about terminal diagnoses like cancer, if I know I've got lung cancer and I'm stage 4, well, I'm probably or may not want to be resuscitated and put on a ventilator. I know that my prognosis is poor. I know that there isn't necessarily a good outlook on if I were to stop have trouble breathing or something happens. I already know that I've got that terminal illness. That means, that my life expectancy is going to be a little shorter than it should, right? So that's a big factor too. Whereas if you've got no other comorbidities, no other diagnoses that you're dealing with, you're healthy otherwise, then you might say, yeah, go for it, because there is a good outlook. There is a good prognosis that I could come off of a ventilator or something. So definitely the outlook. And that's important too. You can specify that, if in a living will.
Right. So, as we're going through, I can understand if like our listeners are like, see, this is why I haven't done it yet. There's so many options, but I do want to reinforce that the resources that I keep saying online, but obviously, doctors' offices, libraries for sure have all of this information to be able to help you. Like I said, people have done a lot of the work for you already. You are able to look at things and kind of just choose rather than coming up with your own language. Because I think sometimes trying to come up with your own language about the wishes seems really overwhelming. I'm going to, if it's okay with you, Kelly, I'm going to read through here some of this language and some of these templates, that I have seen before. And I kind of compiled this from a couple different places, but just so people can hear what kind of language and choices. So I have here, if I should be diagnosed as having an incurable and irreversible illness, disease, or condition that is terminal, then you would be able to get to say things like, um, I still want to be have every single medical procedure that I can do. Still, I still want you to do everything you
Life
can.
sustaining
Yeah,
treatment.
life sustaining
Yep.
treatment to keep me here as long as possible. Or you could say the opposite, right? I don't want anything. um, Another thing, you could say diagnosis having an incurable and irreversible illness, disease, or condition that is not terminal, but causes me to experience severe or worsening physical or mental deterioration, and I will never again regain my ability to make decisions and express my wishes. And then again, you would get to choose those same things. Um, if you are considered, and we discussed this, permanently unconscious, and it is determined that I have totally and irreversibly lost consciousness and my ability to interact with people and my surroundings, then I would, right? And then you get to choose all of those things. And I have it written down. I direct that all life sustaining treatment measures should be taken in any and all circumstances. I direct that life sustaining treatment, which would only serve to artificially prolong my dying, be withheld or ended. I also direct that I be given all medically appropriate treatment and care necessary to make me comfortable and to relieve pain, which I think is always a really great option because you hear that so much. Well, I don't want anything additional to keep me around, but I do want to be comfortable. So let's not do nothing, right? At least let's do some things so that I can, go out and
And
at least.
that's a great piece. That's a great point, is the pain management piece.
Yeah. And then, like you had said, those are some kind of like bulk in general, like all things, no things. And then we can get into like really specific, right? Depending on maybe religious beliefs, family beliefs, just some of these different choices depending on circumstances. That any electrical, mechanical, chemical, or other resuscitation of my heart when it had stopped beating, feeding tube nutrition, hydration by any administration method when I am unable to do so on my own. So this kind of, if you weren't into the all or nothing, there are listed choices that you could say, like, yeah, this is, no antibiotics, anticoagulants, or any type of pain medication, or excuse me, any type of medication at all, except for comfort and pain medication. And then here, the last one, which you had already mentioned, is no hospitalization at all unless necessary for comfort or for pain relief. And we didn't talk about it yet, and we didn't speak about it in our general terms up top, but then we got to talk about hospice too, right? Like, what is
Yeah.
hospice? Because all of these certainly come into play, right? Because when you choose to go on hospice, now I was a caretaker for my father for quite some time until he went on hospice, and then he had passed away. So I am very familiar with this whole process. Like, I am the one that signed his DNR. I am the one that did all of those things. But there are a lot of people that have heard hospice and what that means, but don't quite understand. So could you just talk a little bit about that?
Yeah, hospice is actually, we could go on a whole separate thing about hospice, because hospice is, there's a lot of misconceptions about it. It that word itself is like taboo. Everybody's like you know, you can't even bring it up. Like I remember when my own grandfather was ill, and I talked to my grandmother, and my grandfather had a lot of chronic conditions, including chronic congestive heart failure, COPD for breathing, diabetes. Um, and I mentioned to my grandmother, I said, you know, have you looked into hospice? Hospice? Why would you say that? That's terrible. Don't say that. And I'm like,
Automatically means that he's
hold
about
on.
to die, right? People think that like you do hospice, it automatically means like this person is about
It's
to
like a
die.
death wish.
And that's just
Yeah. And realistically, hospice is incredible because people, first of all, you can come off of hospice. So really the criteria for hospice is just that you need to have a condition that could be terminal within 6 months. I mean, heart failure could be terminal within 6 months. It's not usually, you know, but it's something that if more people probably would be eligible for hospice than they realize. But that doesn't mean you're going to die. You know, it's not a stamp of approval of, okay, we're going to go let you die.
well,
Or it's not, we're going to pump you full of morphine, or, you know, that there's, what it really allows you is pretty much around the clock nursing and healthcare. That's usually your insurance covers that, and it gives you a lot of one-on-one care and management of whatever those conditions are. But the key piece being with hospice is we're not looking to cure anything. We are looking to keep you comfortable, and that would be what we would call that palliative care, where we're not curing, we are helping you through discomforts. And we still may say you're on hospice, but you have a UTI. Well, we'll still give you an antibiotic for a UTI. I'm not going to just let you suffer uncomfortably, you know, with that just because you're on you know, because it's a matter of keeping you comfortable. And so we can treat some things, but for the most part, it's a matter of keeping you comfortable. And it really is a good option in the event that you have something that is looking terminal, that's not necessarily curable.
yeah, and I have to say, I had a wonderful experience with hospice, and I know so many people also that have had wonderful experience with the nursing care. You know, it does take a special type of person to do that type of care, and I know that myself and a lot of people I know have been very, very lucky with that. I did want to mention, and again, insurance could be a totally separate conversation that we are not going to get into, but I think that this hospice thing and this stigma around it and this kind of death wish came a lot from insurance companies being so kind of stingy with being able to pay that you had to kind of be so sick that, you know, and
Right.
I think that in specific is an insurance issue that created that idea. But the actual what it's supposed to look like is something kind of much better, right? Is really just
And most people who do end up utilizing it, or learn more about it, they go, okay, I didn't realize that's what it included, or that's, you know. And I think it's not necessarily, it's not that I'm promoting hospice per se, but it's what's important is that you look into it, right? Or that you don't go, oh my God, hospice, I don't even want to talk about it. And that's another piece, that for the families, if they're put in that scenario, okay, you know, you're, say something happened to me and it's not looking good, do you want to go home on hospice? You know, the families might go, no way, no way. Typically what I tend to see
change,
is,
right? What's gonna the outcome, which it's not. You're right, it's not. It
right, exactly.
doesn't actually.
um
It may change where you are, right? But what
mhm,
I also find is that a lot of these choices and a lot of these options for the advanced directives, you know, are very similar to what people would like to choose on hospice. I find that the people that I have
yes,
known that have gone through the hospice, a lot of their choices and a lot of things that they've chosen do go very well with what hospice offers, which is
mhm,
comfort and care, nothing extreme or extraordinary. We did get to a point with my father, it might have been a week maybe before he passed, where he passive COPD, and he had we knew that he had developed an infection, right? Like things were getting worse and things were deteriorating. And it was a question of, you have chosen. Now he was still, all his head was there, right? He had chosen not to be hospitalized, right? We are going to stay home on hospice, and that's where we're going to be. But this new thing came up, and he was well enough at the time be like, okay, are you gonna, do we still want to stick with this? Like, because at this point,
Right. Right.
like, this is the point where it's like, okay, if you want to be hospitalized, like, we would go now and we would go. Or if you're making the decision not to, then we can stay. And he had chosen not to, and he stayed home. So, but because he had all of his mental faculties, he was able to make that choice again.
Yeah.
But also a good example of making sure that you have that healthcare proxy. So if you were in that situation, it's like, well, no, he needs to go to the hospital. You know what? But that wasn't what he wanted, and
Right.
those things
Right.
already set up. But I do find that um, hospice does fulfill a lot of those common choices that people tend to make. Would you agree with that? Do you?
Yeah, absolutely. And I think you make a good point. You can be on hospice and still be alert and oriented. You can just have a condition that is potentially terminal. And so you have the prerogative to go on hospice and go, you know what, never mind, I do want treatment. And you can seek treatment. You're not like locked into a box of, okay, I guess I'm dying now and it is what it is. I can't change it. You can, these things are fluid and it's your own decision. It's what you want at any time.
Yeah,
So,
so important
you
to say
can
that.
go back and forth. Yeah.
You can change it. This is not like you're writing and you're signing and it is the end all be all. It's like if you did it
Right.
and then the next day you change your mind, all right, well, let's redo
Yeah.
it,
And actually,
sign it, you
that's
change it, right?
exactly. And that brings up a good point because I think too, people get nervous that, oh my gosh, I have a power of attorney or living will. Can that overrule, if I verbally say something different? Right. So like, for instance, if I'm in the hospital and maybe I was a DNR, and I've dealt with this scenario actually multiple times in healthcare where somebody on paper was a DNR and then they get to the hospital and they go, actually, I want it to be a full code. I want to be treated. And we're going, okay, that's that verbal discussion. We have to pull a physician in. There has to be witnesses. There has to be something else written up. But
It's
absolutely,
right.
we update your
Is
living will.
it physicians like
Was
that?
that?
Is it two physicians like that, like, make these calls basically, like these changes, or the like? Is it you have to, like, you're one either regular physician and then like an additional one just for saying things like making determinations, like competency determinations, or
Oh gosh, yes.
like,
Well, if
or
we're talking about competency definitely needs at least two physicians. One of them is usually a psychiatrist. Well, depending on the circumstances, but absolutely to determine competency, there's multiple physicians that would need to sign off on that for
Mhm.
sure. But if it was just somebody who's alert and oriented and maybe had a terminal illness, but then decided, hey, actually, I do want to be
Mhm.
given
Sure.
full
Somebody
life-sustaining treatment, a
actually, I'm
doctor can,
well, right? If they're,
yeah,
I'm feeling better than I thought I would, and I really think I'm gonna fight and
exactly.
beat this. So just
Yep.
kidding, like, save me, right?
Yes, yes. And then at that point, and that's what people I think maybe would get nervous about too, is, well, what if I write it that I don't, and then I change my mind? Okay, then you change your mind. And then we're going with your most current, but you have to make sure that that's documented somewhere. So if you're in the hospital and you voice that opinion, a doctor comes in, he discusses that with you. Usually a nurse is witness. There's something written up, signed by the patient, the physician, another witness or two as well, that there has been an update that based on this hospitalization, you do want to be resuscitated, right? So it can always change. That's the thing. But what's important is that people are paying attention, that they're thinking about it, that if they do change their mind, that they update that living will. And that can be done at any time, but just making sure that they, because another big ethical dilemma we run into all the time is that, maybe a patient has multiple children and one child is the healthcare power of attorney, but maybe in the last couple of years that child became estranged or something happened. And then a different child who's not the healthcare power of attorney has been the caregiver. We run into that all the time. And then that child wants to make decisions for their parent, but they're not the healthcare power of attorney. And then there's a huge, that becomes extremely difficult ethically with families. And I have also seen that a number of times. And so my other really piece of advice here for people listening would be to make sure that they're updating that and that they're not it's not that you're going to hurt your family's feelings, or, you want to make sure realistically that if it comes to you not being able to make your own decisions, that you're choosing the person that you feel at this time would be the best person to make those decisions for you, which, as we said earlier, does change throughout the years. So just making sure that it stays updated.
Yes, I agree with that 100%. And yes, it can get messy, right? We mentioned that it's one of those things. I feel like if I had somebody else that wasn't my child, like maybe that would be better. Maybe you have three children and you don't want the one in charge because you know it's going to be messy. So maybe you choose an uncle or a cousin, So you do want to think about how that's going to affect the family. So I only have, I think, two more questions for you, Kelly. One is, what do you think is the main reason why so many people do not have an advance directive? Do you think it's because it seems overwhelming and confusing? Or like, what are you seeing when you're seeing, patients come in, or even like when you're teaching your students how to approach people and ask them, what do you think is holding people back?
I think there is a lot of concern about, I think, you mentioned about facing your own mortality. People a lot of times don't, they're like, oh, well, I'm not worried about that yet. That's not going to happen to me. Or, it's almost like planning your own funeral in a way. A lot of people don't want to do that, or don't like to think about it, because
which we will be discussing in part 3. So everyone who's listening, part 3 of the Expert Series is going to be funeral planning, because again, it's another topic that we don't want to talk about, but that's important. So just wanted to throw that in there, Kelly. You can continue.
Yeah, for sure. And it is, it's one of those things that we try to put off because we like to pretend that we're going to live forever. When realistically, again, we never know how much time we have on Earth. So, there's a hesitancy. I think that's really the biggest piece of it, or like the whole idea of your, this discussion today of, I don't really understand what that entails and I'm not ready to get into it, or I don't want to write the wrong thing down, or what if I say something and then I box myself into a corner and I don't get, so there's and that's again why it's important to talk about it. And I think at a minimum, even if you create yourself a simple living will, that you have verbal discussions with your loved ones, just that, so that they know from just talking to you what you would want. Even if you have trouble putting it down in the written word, or you feel nervous about, if I make things too specific, what if I don't get the right care, or I trust this person to make the right decisions for me. So you talk to your family about it, and it's okay to talk to your family about it at any age, whether you're 30 or 90, because then they're also going to know, or if something changes, hey, look, now that I've got a couple of these diagnoses and I'm slowing down and stuff, I really don't ever want to be intubated, or I really don't ever want to be, prolonged artificially living, or, and if that's vocalized just between family members, even if it wasn't written down, at least you've had that transparency, and it's going to make the families feel a little more confident in knowing what you wanted.
You can say, you guys will all be in the waiting room and you have a doctor come out saying things, and you can say, listen, a few months ago I had a conversation with Bob, and we talked about this, and he had mentioned this, and so maybe we should take that into consideration. Just those things as you're trying to make decisions help a lot, right?
Mm-hmm. Yep, for sure. And I feel like that's even more important than even writing something down, almost, is making sure that you are talking to, unless, and of course there's people who don't have any close family. And so then I would absolutely say the more specific you can get, the better. But if you've got somebody in mind that, look, if something happened to me, I know this is the person I would want to make my medical decisions. Mm-hmm. It's important to talk to them, and make sure that they understand that they're on the same page with you, because it's I can tell you from experience that most often the family is going to want to pursue the most possible, the most aggressive treatment, usually for their loved ones, because of that anxiety of losing them. So, if you are somebody who says, look, I don't want to be kept alive artificially, or if I'm brain dead, pull the plug, or, if you feel that way, you've got to talk to your family about it, because pretty often we see that the families are like, nope, 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 I'm keeping them alive. We're doing everything we can to keep them alive,
And
and then that's a whole other.
so even when you say you're not going to do that in the moment, and I can say from experience, and so many other people can, in the moment, it's really hard. It's really hard.
Yeah.
So that's why it's so important to have it written down. One of the other things you had mentioned, if people don't have friends or family, I just wanted to let everyone know you can always talk to your doctor and your nurses. You can always talk to your medical professionals and say, hey, what do you think and how can I do it? Right. And they will make sure that you can get set up with somebody if you need
Absolutely.
to create something. So always ask your medical professionals as well. And the last thing that I want to touch on is really important, and it's organ donation. And I want to talk about this one, because it is something that some people feel very strongly about. It is a really simple, easy conversation to have with our loved ones. Is this something you think you want to do? Is it something you don't think you want to do? Of course, we can get into the nitty gritty of circumstances, but sometimes it's not kind of as complicated. And make your wishes known. And I have been freed to talk about this. My husband and I spoke to my husband about it, and I said, "Can I talk about you?" And he said, "Yeah." But I personally want to donate all my organs. Just my personal thing. I feel like take it. I don't need it. I'm cool with that. And I'll never forget the conversation I had with my husband, which was, hey, babe, like, what about you? And he was like, uh-uh. And I was like, what do you mean, uh-uh? And he's like, mm-mm, I don't want, nobody wants my things. And I was like, first of all, that's not true. But I said, if you feel that way. And he's like, yeah, I don't want to. And I remember like trying to convince him, and he was like, you're not going to convince us how I feel. And I was like, okay, but I'm going to tell you, if we didn't have that conversation, because of how I feel about it, I probably would say do it. Right. But he doesn't feel very strongly about it. So now I know. And if the situation were ever to arise, and I keep my card with me in my wallet, and it's also listed on, there's so many apps and things like that now too, that the medical professionals have, that you can put those things. But there are certain circumstances, though, I know, with organ donation, like in hospitals, like in a situation of hospital, like, because organs do have to be kept viable in order to be donated. Some people don't think about that. Some people say, oh, like I want to go on hospice, but I want my organs donated. And that can get very, very complicated, because from what I understand, there's like timing issues, and we don't have to get involved in all of that. But I do think that it's something that needs to be kind of written down and then acknowledged when we're making our plans, that that's included.
Yeah. So organ donation, at least in New Jersey, right? You opt in on that most easily when you're driver's license. Yeah, right. So you motor vehicle, and it's interesting that that's where you do it, because if something happens, it's all right there on your driver's license. If you're in a car accident or something happens and we're trying to save you, or we save you, but you're artificially alive, right, on life-sustaining treatment, we know right off the bat exactly where you stand on that. But if it's not listed on there, or then they're going to look to that living will, or they're going to talk to your power of attorney and say, what do you want us to do with this person? And I think a lot of people do have a lot of anxiety about that too. I mean, just in my own personal experience, when I got my driver's license and I chose to be an organ donor, my mom flipped a lid.
Really?
Back. Yeah, she goes, no, you can't be an organ donor. I don't want them to kill you and take your organs if something happens. I said, Mom, they can't, and there's that common misconception there. I think that people think if you're an organ donor, then we need your organs to be viable, so we're going to take them while you're still alive.
Right.
So I think there's a lot of anxiety about that, about, what if, does that mean they're going to let me die more quickly because they want my, I think that's a true fear from a lot of people that I've talked to. And realistically, it's important for people to understand that no, nobody can take your organs while you are alive and you have a good prognosis. There's an outcome of that you're going to be better. When I say alive, though, right, realistically, like you said, we can't harvest organs on somebody who passes away after so many hours, and every organ's a little bit different as far as like how fast you need to get it. But what happens is if you're an organ donor and say you got into a really bad car accident and you were being kept alive on a ventilator and you were completely brain dead, then we try to keep that body sort of viable so that we can then call the organ donation company. With New Jersey, it's Gift of Life. Everywhere might be a little bit different, but they would come in, do an assessment, talk to the family, make sure everything is kosher with what is able to be harvested and what isn't, and then they go from there. So nobody's pulling a plug on you just to take your organs, and I think that's a lot of times a very that's one thing that I hear a lot, that people are nervous to be organ donors. And realistically, you can save a lot of lives by being an organ donor, but that would only be if the circumstances were really perfect. You'd have to be in your body would have to be in pretty pristine condition, but you either are passing away or suddenly pass away or you're brain dead. If we can keep that body sort of, the circulation and oxygenation sort of flowing with enough time, then we can potentially, use those organs to help other people.
Yeah. I just wanted for people to keep that in mind as they're doing their living wills, to make it known, what their wishes are and how, again, the circumstances of that, right? So I think that we've touched on pretty much everything. I mean, we've talked about a lot of really wonderful things. Is there anything kind of left over that we're missing or that you want to reiterate or discuss?
No, I think we talked about a lot of things. I think just overall making sure that people understand they don't have to be scared to make these decisions, and that they don't also have to be old to make these decisions or near death. It's something that could be done at any time, and it can be pretty straightforward. I mean, if you just go onto your smartphone in the App Store, there's apps on creating a living will right through your phone, where they're going to do the same thing as those online forms. They're going to prompt you with questions, yes, no, and then they can generate that for you. So it can be, it is a very daunting and nerve-wracking task, but it doesn't have to be. And even if you have some things written down, it's better than nothing written down, because it's going to take a lot of any potential confusion or anxiety away from family members and also healthcare providers. And so I think it is just, it is an important discussion for people to know that they can do it at any time.
Yeah, that's great. And what I would add to that is the same thing of, you can make it as easily and complicated. And I know for myself, I told you I called myself out a little bit that I'm doing these presentations on this, and mine is still not complete. And in writing, and just sitting here thinking about it, and I was like, well, there's no reason why I can't do like a quick, simple, easy thing and have it done, and then I can sit down, and do even a more complicated one, but just getting something down. And for our listeners, so part 2 in the older adult expert series is going to be sitting down with an attorney and talking about preparing for things legally. Not just an advance directive, but everything, right? Just basic estate planning. We're going to talk about what we can do to make sure that our wishes with everything, not just our health, are taken care of. So we do touch a little bit about this. Again, like we mentioned, you do not need an attorney to have this put in place. However, if you're working with an attorney to do estate planning and basic wills, you certainly can add this and throw it into the mix at the same time and get everything done, which is what I'm planning to do. So thank you so much, Kelly, for coming on and talking.
Thank you for having me.
All of your medical expertise, and I know that a lot of people have gotten a lot of great information out of you today. So I can't thank you enough.
Sure, thank you for having me, and hopefully this helps clarify at least some questions. But I think, again, if there's additional questions, it's just, just ask, write things down when you go to your doctor next time, ask those questions, because the more the better, you'll be able to prepare for those sorts of things. So.
Yep. And like I said,
thank you.
Oh, no, you're welcome. I'm going to put a list of a whole lot of resources at the end of this so that people can take a look and see. I'll put maybe a name of some apps on there along with some websites and just some phone numbers to call for people that aren't like real tech savvy, but still want to have some conversations about it. So that's going to be good. So thank you again. And hopefully one of these days we'll get to see each other again. It's been a
Yeah.
couple years since I actually saw you in person pre-pandemic. So hopefully we'll
Yeah,
see you soon.
pre-pandemic, yes. Yeah.
All right.
Hopefully things are looking up.
Seems like it. We're getting better.
Yeah.
All right.
Yep.
So we'll talk soon. Thank you again.
All right, Lisa,
All right.
no problem. Have a great day.
You too. Bye-bye.
Bye.
Over the hills and far from what she's waiting for love.